It is our privilege to invite the next speaker, Dr. Shrikant Sahu, for presenting the Odisha State Ophthalmological Society Best Paper, Outcomes of DMEK with or without peripheral iridotomy. Welcome, sir.
Thank you. Shall I go?
Yes, please.
Good morning, everyone. Today I will be talking about outcomes of DMEK with and without PI. You see the picture of PI here in the left and without PI on the right. So DMEK, as you know, is a very precise and targeted procedure, which to replace the malfunctioning endothelium. To put the scroll in place, we put air bubble so that it gives a tamponade for graft detachment. But it has its own fallbacks. It leads to pupillary block in some cases and with a raised IOP. So to prevent that, we do a PI normally, what used to be done. So this PI could have been done by YAG or during surgery, most often during surgery. But while doing a PI, it has two probable complications. One, it risks to high amount of bleeding because they are already inflamed eye. Two, there's a lot of pigment dispersion. The other aspect is their glare and photo which can happen. In the year 2018, Linvi et al. First said that okay, it can be done without PI. So then the thought process started that can we avoid this PI that does, but without compromising with the outcomes of the DMEK. So what we did compare the results of DMEK with and without PI, and to analyze the risk and associated benefits of both approaches. So we included all patients of DMEK with or without PI from January 2019 to March 2023 with a follow-up of 6 months, minimum 6 months. So we had in total 90 patients, 33 of them had DMEK with PI, 57 did not have a PI. The primary outcome measure was pupillary block. The secondary outcome was graft detachment, rebubbling rates, and best corrected visual acuity. If you see the baseline characters of both the groups are similar. It had equal numbers of phakic and pseudophakic eyes, the nearly similar amount of Fuchs and PBK. The glaucoma was 6% with PI and 10% without. So basically baseline characters of both the groups were same to start off. Now we come down to what did we see. We saw that the hyphema, which was our main concern, was around 10% with PI and around 3%, 3.5% without PI. Though the numbers were less, but it was not statistically significant. The pupillary block was again half without PI, but not statistically significant. What was surprising to us that the graft detachment was much less without PI, and it was statistically significant. And the visual acuity were better than 20/40 were actually similar in both the groups, a little higher on the without PI group. Now, if you see this more closely, which are the grafts which failed? There were 6 in the group where 33 patients were there with a PI, and there were 10 without PI. So, if you see, actually wherever there was hypema post surgery, the graft failed. So that means if PI is done and hypema happens, the graft will fail. So if we skip PI, it brings there are two advantages. One, the graft becomes more predictable, the outcomes are better, and it saves some time for the patient, for the surgeon also. Because the time for two things. One, to do the PI, and if we have seen that the graft detaches more if PI is done, so second surgical time. What was a matter of concern, why we did this is because Indian eyes are more prone for angle closure. So PI was more prudent and more necessity. But over the years we have seen it's not necessary because even in India it's very safe. So if you compare all the studies historically, of late in 2023 only two publications have come in. Our studies were equally good in terms of pupillary block, rebubbling rate, which was 30%, also actually better than many of the studies. It was only 17% of rebubbling. If you see the graft detachment, it was much better than many other studies. So to conclude, DMEK without PI gives a comparable long-term results in terms of visual acuity and graft survival. The graft with PI can have more chance of immediate post-op complications like pupillary block and hypema. So avoiding this step, we can have a better surgical time, better efficient and more predictable surgery. Thank you.
Thank you very much, Doctor. This was something new or old, where PI was a practice in cataract surgery. Now it is something that you recommend in these cases. With what intention you want that this should be done?
This should be, PI should be done.
Yes, whatever was the message of your study.
So the intention of present study is that every surgery goes through a phase, as you said, through a phase of transition, and we improvised, and a small step of improvisation each time helps to a better outcome and a better, like as we saw, the complication rates were decreasing, the vision, it becomes more predictable. So over the time, we cannot stay with the same thing what we were doing before. We have to move one step ahead and make it more safe, more predictable surgery.
Thank you.